Hello. Thank you so much to the organizers of this meeting. I'm going to start saying that I'm a bit disappointed because I was expecting that for the anthem we'll start with "Oh Cannabis," but this didn't happen, so that's why I refused to sing. So this is a bit about me. I'm a specialist in clinical matters. Also, I do research and I'm an academic, so as a professor. And I don't have anything to disclose regarding this presentation. I don't have shares in any of the companies with licensed producing cannabis. And some of the treatments that I'm going to be mentioning today, they are off-label, so they are not formally approved for clinical applications yet because of lack of evidence. This is outline of the presentation, and I cannot brag about my knowledge in botanical science. You will humble me very much if I start talking about what's something that you know very well, but I cannot bore you to death talking about deep medical aspects of medicinal cannabis. So my talk is going to be touching medicinal aspects of cannabis in a way that I hope that you will grasp the basis of this matter. I will be talking about the endocannabinoid system, the different products available, and in particular, of course, the topic of today's presentation, which is medicinal cannabis, and some aspects of how to do things. An endogenous system is made of three elements. There are endogenous receptors, endogenous ligands, and endogenous metabolic control. And you might make an analogy with other systems that we know very well in the field of pain, and you all know that we have our own opioids, and we have our own endorphins, that they act on our own receptors, and we have our own metabolic control to deal with those products. The same is true for cannabis. So we know that there are so far two receptors described, CB1 and CB2. There are ligands that they are attached to these receptors to create an action. The two main endogenous cannabis products, they are anandamide and 2-AG. And there is a metabolic control to manage the levels, to modify the levels of these products in order to increase or decrease their actions on their body. These endogenous cannabinoid receptors, endocannabinoid receptors, they can be found throughout the body. Mostly the CB1, they can be found brain, lungs, they are widespread located. CB2 seem to be more present in immune-related organs, like for example the spleen or bones, and there are organ tissues that they co-localize or where we can confine the CB1 and CB2 receptors. But where these receptors are placed, it shows what type of actions these are causing. And we know very well that the main effect of cannabinoids on our body functions, which by the way are crucial, are in matters related to the nervous system, in functions like decision-making, cognition, emotional reactions, memory, but also other functions like, for example, temperature regulation. So the endocannabinoid system is crucial for our normal homeostasis, for our normal well-being, but also for other functions like, for example, increase the glucose uptake, in particular for CB1 actions. It affects the sensation of hunger, of needing to eat, and also affects the way that we feel when we eat a palatable food. So it does affect also the gastrointestinal system. And the CB2 receptors, they seem to be a bit more related to immune systems. And this is an immune and inflammation. So this is probably why CB2, they seem to be having a bit more interest in the field of, for example, pain, which is my field of expertise. how can we activate those receptors? So I want to present some exogenous agonist or antagonist on these receptors. So you know that an agonist is the product that activates a receptor, and the antagonist is the one that blocks the receptor. So for you to understand how cannabis works, you will understand that a CB1 receptor antagonist, in fact, is an inverse agonist. Inverse agonist is the one that occupies the receptor but does not activate it. So Rimonabant was a medication that unfortunately was withdrawn from the market because of side effects. But when you take that medication, you don't feel like you want to eat. Therefore, activation of endocannabinoid receptors, it activates appetite, which is a very well-known effect when you smoke a joint and you feel like you want to eat. And I'm not going to be assuming that you all have tried, but according to the evidences and the numbers in the literature, I might assume that this is something that eventually it's quite frequent. Then we have synthetic antagonists. So these are not naturally occurring products that we can use to activate these receptors for a medical purpose. Nabilon and dronabinol are the two options available in the market. Actually, dronabinol is less available now in Canada, but Nabilon by far is becoming one of the drugs most commonly used when you want to activate cannabis receptors for the purpose of a medicinal action. In particular, it is recommended to prevent and to treat nausea and vomiting in patients receiving chemotherapy. But also, we have good evidence to support its use for pain management. Dronabinol, it has been approved to treat anorexia, which is lack of appetite, in patients with HIV and AIDS. But also, it's a good adjuvant to prevent nausea and vomiting for patients with chemotherapy-induced symptoms. Nabiximols it's not a natural product, but it's taken from the plant directly, and it mixes two products that I'm going to be talking about now, THC and CBD, two of the main alkaloids present in the plant, and in particular has been approved in Canada for the use of cancer pain relief, of nerve-induced pain relief, and for symptoms related to multiple sclerosis, which can include pain and also spasticity. So by looking at how we use cannabinoids to treat symptoms, we understand how these receptors, they are functioning in our body. But the topic of importance is cannabis. So why cannabis has an organic effect on our body? It's due to two main components, phytocannabinoids and terpenoids. There are also phenolic compounds that they have certain effects, but the knowledge in this field is less obvious. Therefore, right now, when we talk about the medicinal properties of cannabinoids, mostly we're talking about phytocannabinoids and we're talking about terpenoids. The good news is there is something in the plant that works. The bad news, we don't really know exactly what, because if we look at the literature, apparently there are more than 100 different phytocannabinoids in the plant. So there are many different products in a plant that works. So that's why when someone says, cannabis helps me, I have a hard time understanding what exactly in that plant is giving the patient a positive effect. The same is true for terpenoids, which you know well because terpenoids are widely distributed in vegetables. And also they have a therapeutic effect. I want to go over phytocannabinoids and terpenoids very briefly. Some examples of possible phytocannabinoids that they have a potential effect in our body. The most common one that we all know very well is the delta-9 tetrahydrocannabinol, which we all call THC. This is the most. This is the alkaloid, the phytocannabinoid, with the most strong effect on our brain in terms of producing eventually hallucinations, calmness, sedation, and pleasantness. But there are other cannabinoids available that also have a therapeutic effect. And in particular, I want you to point your attention towards CBD, because CBD seems to be the one that possibly in medicine we're going to be using more often. And I'm sorry that the slide is very busy, but you can see that there are evidences suggesting that each cannabinoid could be providing differential effects. So there are cannabinoids with more effect to fight nausea. Some others, they might increase appetite. Some others, they might fight anxiety. Some others, they might help you sleep well. And some others, they might help you fight your pain. So that's why it's so challenging for us clinicians to know what is in the plant. And then terpenoid, as I said, this is another product that with potential therapeutic benefits. We know that they are distributed throughout the vegetal realm, and we know that also they can come with some potential benefits in terms of pain, inflammation, anxiety, nausea. So all to say that the field is very complex, and the amount of knowledge that we have is growing, and we're growing very fast. But we still need to learn. In fact, there are evidences suggesting that cannabinoids, they are effective to treat certain symptoms. And science tells us that compared to nothing, compared to a placebo, cannabinoids, they show evidence. In particular, the studies done, they are mostly done with products that they are well known. Of course, you have to understand that there's no use in trying cannabis in general when you don't really know what exactly you're trying. So all the evidences, they come from studies where a certain product at certain doses, given at a certain, with a certain administration route, can be compared with a placebo to see whether the product helps or not. In particular, the evidence says that there is a moderate quality of evidence to support the use of cannabinoids, in particular to treat chronic pain and spasticity, but also to improve nausea and vomiting due to chemotherapy, to regain weight in patients with HIV, also to treat sleep disorders. And I'm sure that you all have seen that video from this very young patient with very continuous epileptic seizures. After taking a CBD oil, epilepsy is gone. So this was close to a miracle. The best evidence so far for the use of cannabis is in the field of pain. So that's why possibly we pain clinicians are the ones that they are in the front line to experiment with these new products. In particular, pain due to nerve damage, and more importantly, pain due to cancer. Because cancer comes with symptoms like pain and other symptoms that potentially might benefit from cannabis, like, for example, nausea and vomiting, and lack of appetite and anxiety. Health Canada has suggested some indications to guide us clinicians to find the best candidates. And again, as I said, pain is probably one of the most important ones. But there are many others. In terms of variety, the market keeps growing. The number of licensed producers keeps growing. According to this slide that I'm presenting, in 2017, there were 34 licensed producers, but the number keeps changing and growing with new acquisitions and larger companies buying smaller companies. And in particular, in the Canadian market, the number of kilograms of cannabis sold legally, it keeps growing. In fact, recently I learned that once cannabis gets legalized, the licensed producers will be able to provide roughly 30% of the Canadian needs for cannabis. So I can see that there is a future in buying shares in those companies because they are going to be growing a lot. A bit of botanics, but I will not torture you very much. We talk about cannabis sativa and cannabis indica. From the point of view of pharmacotherapy, it looks like there's one that it's more sedative and there is another one that it's more activating. So I always remember that the indica is the one that seems to have less THC and has more CBD, therefore is more is less sedative and it's more activating. Whereas the sativa is the one with higher doses of THC with potential effects on sedation, which eventually can be good if you really want to calm yourself down and maybe sleep. So this is one of the first choice. We want to give a sativa, we want to give an indica-based product to our patients. This is one option, but we clinicians were talking CBD THC. This is an old graph of, I think it's 2014, where you can see some of the licensed producers and the different options available in the market. The way we talk about cannabis now is how much THC, how much CBD we're giving, or the plant that or the product that we are using, what is the percentage of one versus the other. The same way that we don't give opioids, we give OxyContin, we give fentanyl, which are names that are a bit dangerous lately, I know, but we need to understand what exactly we're giving to our patients, because we try to do it in a way that it's rational and safe, and we need to speak to each other in a way that we understand, at least among us physicians. So it looks like THC, CBD right now is the right language to talk about cannabis. THC being analgesic, being euphorizing, but also sedative, and with some other effects, like, for example, to treat nausea and vomiting. Whereas CBD seems to have an effect on anxiety, for example, and also in the field of pain. In the market, you will have products with high THC and no CBD, and with high CBD and no THC. And this is thanks to genetic modifications and the way that producers, they grow the plant. But also now in the market, you can choose whether you want a product with more limonene, with more, sorry, I cannot see, myrcene, for example. So different terpenoids eventually might be more helpful for certain patients. More and more knowledge that we need to adopt in our practice, which is challenging. But once you think that you know what type of product you want to use, the next thing you need to think of is how I want to give this product to my patient. Do I want the patient to smoke, to vaporize? I want to give an oil and eventually take it per mouth? Do I want to give a cream, a topical remedy, maybe a suppository? So right now, as clinicians, we are trying to manage medicinal cannabis with two products, or two administration routes. The oral route, which is slow-acting and long-lasting, and the vaporized route, the inhaled route, which is fast-acting and short-lasting. For you to understand, is like in other products, we have the long-acting medication and the short-acting medication. We have these options in opioids, for example. This is more or less the same thing. For you to understand, we don't encourage people to smoke, because the smoking causes, actually you need more product to get the same effects. So you make more for the same product if you're using it vaporized, and also you avoid inhaling products that potentially can cause cancer. Side effects. The classical side effect that we all know from cannabis is the sedation. But sedation might be something that eventually you want to have. Also hallucinations. That's why certain cannabis products high in THC are not well indicated in patients with history of schizophrenia or bipolar disorder, those with hallucinations, because eventually might lead to more of those crises. The classical side effects of the medicinal cannabis we're dealing with are dry mouth, and somnolence, and dizziness. These are very mild side effects, and in general, in the literature, the rate of these side effects is very, very minor. What about interactions? We're getting to know that medicinal cannabis might interact with certain products, with certain drugs that eventually we might be giving to patients. In particular, certain cannabinoids might interact with warfarin, which is a medication that we use to thin our patient's blood. It's an anticoagulant. So we need to know more about these products. For obvious reasons, a medication which eventually might cause some drowsiness might interact if you're taking Valium, for example. You might be more drowsy. So eventually we might account for a sum of other effects, or summative effects, if you're taking two drugs with a similar effect. Can you get addicted to cannabis? According to the literature, not really, at least not physically dependent. However, it has been shown that in the field of psychiatry, there is cannabis substance abuse that it has been properly described. But compared to narcotics, opioids, the use of cannabis and the rate of addiction is at a much safer level. What about driving? Right now, you know that the legislation says that we should not be driving when we're high. And the same is true for narcotics. So right now, what we're telling our patients is that if they use a cannabis oil, they should not be driving within 6 hours of taking that medication. If they use an inhaled cannabis product, it should be within 4 hours. And most important, if the patients, they feel high, if the patients, they feel drowsy because of the cannabis, they should avoid driving within 8 hours. I can tell you that the CAA is going to jump a new study with volunteers. You might want to present yourself. They are going to be, actually, they are looking for young, healthy volunteers who are going to be given the product, and they are going to be using a very fancy driving simulator, and the CAA is going to see whether different products, how they can affect the driving capabilities. I encourage you to be in that line. It might be fun. I'm almost finishing, and I just want to point out that it is very important that, as it happened with narcotics, we have to make a big difference between recreational and medical purposes. And now that cannabis is going to be widely available, starting in July, when someone comes to our office claiming that cannabis helps, we want to investigate what type of help the patient is getting from the product, because we cannot afford another crisis, and we all know what has happened with opioids. It's true that cannabis seems to be safer, but again, we need to be very careful. In my eyes, cannabis is a more natural product. There is a very long experience with the human use for centuries. The experience and the evidences, they are growing with the plant, actually, and it's very safe. However, we don't have the medical knowledge yet, so we are investigating, we're acquiring that knowledge. We're seeing some cannabinophobia, so doctors and clinicians who don't want to get there because they feel that it's going to be bad for their patients. Unfortunately, some people, they look at cannabis as if it was a miracle, but cannabis is not a miracle. It might help, certainly, among many other things that we can offer to patients. And right now, we clinicians, we see ourselves a lot of pressure from patients asking us to do something that so far it's only for investigational use, and from the society. And with that, I thank you very much for your attention.